Ladies and gentlemen, my name is Daniel Ronik. I am an obstetrician and gynecologist working with maternal-fetal medicine at Monash University in Melbourne, Australia. I'd like to thank the organizing committee for the invitation to be here with you today. And I'm going to talk about early prediction and prevention of preeclampsia. This is an area where extensive research has been conducted in the last few years, and I'll try to give you an update with a focus on prediction at 11 to 14 weeks of pregnancy and low-dose aspirin. Why is preeclampsia an important condition to screen for? Well, it is a relatively common pregnancy complication. It affects between 2 and 5% of all pregnancies in high-income countries, and even more women in developing settings. There are more than 6 million women being affected by this condition every year throughout the world, and it is an important cause of maternal death, both in developing countries as well as high-income countries. In the United States, for example, preeclampsia accounts for 1 in 5 of all maternal deaths, and there is one mother dying from complications of preeclampsia every 12 minutes somewhere in the world. Preeclampsia is also an important cause of prematurity. About 15% of all premature deliveries are indicated because of complications of preeclampsia, and the problem does not finish when the pregnancy ends. If women who had preeclampsia are 4 times more likely to die from cardiovascular causes and develop cardiovascular complications later in life compared to women who did not have preeclampsia in their pregnancies. So it is an important condition to try and identify a high-risk group of women who are more likely to develop disease. These are 2 of the most widely used guidelines around the world. The one on the left is the NICE guideline published in 2010 in the United Kingdom, and the one on the right is the guideline proposed by the American College of Obstetricians and Gynecologists in 2018. Both guidelines give us a list of 5 high-risk factors, which are the same: previous preeclampsia, chronic kidney disease, chronic hypertension, diabetes mellitus type 1 or type 2, lupus, or antiphospholipid syndrome. And a list of moderate risk factors that are very similar between the 2 guidelines and include first pregnancy, increased maternal age, increased maternal body mass index, pregnancy interval more than 10 years, and family history of preeclampsia, and in the American guideline, also Black ethnicity and poor socioeconomic status. Both guidelines state that if you have 1 or more high-risk factors, or 2 or more of the moderate risk factors, you should be considered high risk for preeclampsia and offered treatment with low-dose aspirin. There are 2 very obvious problems with these guidelines. One is that they were basically developed based on consensus among experts, and they were not really tested before clinical implementation. And 2 is that, as you can see, they attribute very similar weights to very different risk factors. In 2018, we conducted a large study in 6 hospitals in the United Kingdom, where we applied the NICE guideline criteria to almost 17,000 women presenting for an 11 to 14 weeks ultrasound. We also followed these women up during pregnancy. We collected data on aspirin use, as well as pregnancy outcomes. We identified that about 10% of the population is screened as high risk for preeclampsia at 11 to 14 weeks. But unfortunately, using this criteria alone only identified 30% of the women who have preeclampsia. This means that 70% of women who develop preeclampsia later in pregnancy were considered low risk according to the guidelines. And even if we look at more severe disease before 37 weeks, only 40% of these women were classified as high risk. As I said, we collected data on aspirin use, and among the group of women at high risk, where 100% of them should have received aspirin, we found that only a quarter of these women received an aspirin prescription from their health professionals. So the guidelines fail to identify a high proportion of women who have preeclampsia, and also health professionals don't seem to adhere to the guidelines very well and don't prescribe aspirin to a high proportion of high-risk women. In Australia, the situation is very similar. We use a very similar guideline to screen, and only 1/4 of the high-risk women receive an aspirin prescription. Data from Canada shows even lower compliance rates, and of all high-risk women, according to the Canadian College of Obstetricians and Gynecologists, only 10% of those received an aspirin prescription. An alternative approach to screening, however, is to use mathematical models to estimate each patient's probability of developing this disease. This is very similar to what we already do for Down syndrome screening, where we calculate an initial probability based on maternal age, and then we incorporate markers as nuchal translucency, free beta HCG, and PAPE to estimate the adjusted individual probability of Down syndrome. Here, we can use maternal history and medical characteristics, previous pregnancy characteristics, to estimate an individual initial probability of having preeclampsia, and then we can combine that with biomarkers to estimate the probability of developing the disease before any given gestational age that we want. We have studied many biomarkers in the first trimester, and these are the 3 good biomarkers at 11 to 14 weeks. Uterine artery pulsatility index on Doppler ultrasound is one of these markers. You can see that the blue line is the average value among women who will not have preeclampsia, whereas the red line is the average value in women who will have preeclampsia according to the gestational age at delivery. And one thing that you can see is that the uterine artery pulsatility index on Doppler ultrasound at 11 to 14 weeks is significantly elevated in women who have preeclampsia, particularly in those who have early onset disease. And there is almost no difference between cases and controls in women who develop late onset preeclampsia. The same goes for mean arterial pressure, which is already elevated at 11 to 14 weeks in women who will have preeclampsia compared to those who will not. And the difference is larger the earlier you have disease. There are 2 good serum biomarkers of preeclampsia at 11 to 14 weeks. The main one is placental growth factor, which is significantly reduced in women who have preterm preeclampsia. And the other one is PAPE. The reason why PAPE is not in this slide is because there is a big overlap between PAPE and PLGF, and PAPE does not add to the detection rate when PLGF is already included in the risk calculation. So in summary, we can estimate an initial probability based on maternal characteristics and medical history, and then combine these 3 biomarkers, uterine artery pulsatility index, mean arterial pressure, and biochemistry, to then calculate each person's risk of having preeclampsia before a certain gestational age. And if we do that, we can define a certain cutoff that we want to work with. And if we use a cutoff of about 1 in 100, we will detect about 80% of the women who have preeclampsia before 37 weeks, and even more of those who have preeclampsia before 34 weeks. So this is essentially doubling the detection rates compared to the NICE guidelines criteria when maternal history is used alone. Now, it's very important when we do this type of screening that we make sure people are measuring those biomarkers correctly, and there are protocols and standardized ways of measuring these biomarkers. This is the protocol for measurement of uterine artery pulsatility index at 11 to 14 weeks. It's slightly different from 2nd and 3rd trimester of pregnancy. And the way we do it is by using transabdominal ultrasound. We identify the cervix on a sagittal view, and then we go with the transducer from one side to the other and identify the uterine arteries at the level of the cervical os. We then use a sampling gate of 2 millimeters, an angle of less than 30 degrees, and we apply power Doppler. And our peak systolic velocity should be above 60 centimeters per second, indicating that we're measuring the right vessel. We then use the average pulsatility index by dividing the left and the right values by 2, and we plug that into the software that will calculate the risk for us. Now, it's very important to say that we need to use that as a continuous value. We don't have specific cutoffs for the uterine artery Doppler alone, and as a single marker, it does not perform well, and the notching is almost always present in the first trimester. So it's a poor marker of disease development by itself. In terms of mean arterial pressure, again, we measure it using a standardized technique by using automated calibrated devices that are validated for use in pregnancy. The woman should rest for 5 minutes before you take the measurements with the arms supported at the level of the heart. We use an appropriate cuff size for the arm circumference, and we take 2 measurements on the right side, 2 measurements on the left, and then we use the average of the 4 measurements to calculate mean arterial pressure, which will then be plugged in the software that will calculate the risk for us. Well, it only makes sense to predict disease if we have an effective intervention that follows screening. And we have tried many things throughout the years to try and reduce the rates of preeclampsia. And the reality is that very few of these things work. I'll show you in the next slide. We have tried bed rest, reduced salt intake, exercising, avoiding exercise, chocolate, we tried fish oil, we tried to supplement many vitamins and minerals, we tried calcium, many studies done with aspirin, and these interventions here in purple are the ones that are currently being evaluated in randomized trials. A summary of these interventions is that the rate of preeclampsia is not modified by bed rest, by restriction of physical activity or salt intake, or by supplementation of magnesium, zinc, folate, vitamin C and E, or fish oil. We know that in women with poor calcium intake, calcium supplementation reduces by half the incidence of preeclampsia, but it does not seem to work in women who have adequate intake of calcium. Now, aspirin has been around for a very long time, for more than 3,000 years. And the first randomized trial looking at the possible effect of aspirin in pregnancies complicated by placental insufficiency-related disorders dates back to 1985 and was published in The Lancet. This was published by a French group, and this group conducted a small randomized trial of women who had previous preeclampsia or previous fetal death or severe fetal growth restriction. And they randomized half of these women to receive aspirin at 150 milligrams from 12 weeks, and the other half to receive no treatment. And what you can see on the right side of the slide are the rates of preeclampsia, fetal death, and severe fetal growth restriction in the group that did not receive treatment in pink, and in the group that received treatment with aspirin in blue. And you can see a striking difference between the groups in regards to these complications of pregnancy. So this was the first randomized trial, small in size, but relatively well conducted. And since then, more than 40 trials were published on aspirin use for prevention of preeclampsia, using many different inclusion criteria, varying different doses of aspirin and starting at different times of pregnancy. This was an individual patient data meta-analysis that was also published in The Lancet in 2007, including 24 randomized trials of aspirin use in pregnancy. And a lot of the excitement about aspirin vanished when this study was published, because although the difference between treated and untreated was statistically significant, the reduction of preeclampsia was only about 10%. But if you look into more detail into the studies that were included in that meta-analysis, you find that the vast majority of the studies gave a dose of aspirin below 100 milligrams, and 21 out of the 24 studies started aspirin too late, after 15, 16 weeks. In addition, we see that 15 different definitions of preeclampsia were used among these 24 trials. Later meta-analysis done by a Canadian group showed that if you start aspirin before 16 weeks, there is a significantly reduced rate of preeclampsia when you take aspirin, but that does not apply if you start after 16 weeks of gestation. In addition, preeclampsia seems to be mostly affected in its preterm forms by aspirin intake, and not so much by aspirin intake when we look at term disease. These authors also showed a very clear dose-response relationship and suggested that aspirin at doses below 100 milligrams probably don't have a significant effect on preeclampsia, so the dose should be above 100 milligrams. We then decided to conduct a large randomized multi-center placebo-controlled trial in Europe, and this study was conducted in 13 different hospitals across Europe, applying the Fetal Medicine Foundation first trimester combined screening for preeclampsia as a screening test for inclusion, and using a dose of aspirin of 150 milligrams starting between 11 to 14 weeks and stopping at 36 weeks of gestation. We randomized about 800 women to each group, and our primary outcome was preeclampsia with delivery before 37 weeks. As you can see, this is the result of the primary outcome here. There was a significant 62% reduction in preeclampsia before 37 weeks in women who received aspirin compared to placebo. Interestingly, as you move towards more severe forms of preeclampsia, the magnitude of the effect also goes up, with an about 90% reduction of very early onset preeclampsia and no significant effect in term disease. We also looked at the effect on length of stay in the neonatal intensive care unit of children born to women who took aspirin and who took placebo. And we found that babies born to women who were on aspirin and went to the neonatal intensive care unit stayed on average 21 days less than children born to women in the placebo group, which was largely driven by a reduction in preterm birth before 32 weeks, and preeclampsia accounted for 86% of these deliveries in this high-risk group. We know very well that preterm birth, particularly those born before 32 weeks, have significantly impaired work capacity, higher risk of cerebral palsy and death in the first few years of life. So this is definitely an important outcome to look at. I wanted to share with you a very recent study that was published by another group in the UK, where they applied the combined screening routinely in their hospital, and they compared post and pre-implementation of screening. And these are the rates of preterm preeclampsia less than 37 weeks when they use the NICE guidelines alone. And this is when they implement screening, and that's what happens with the rates of preeclampsia after implementation of screening. So a massive reduction in the rates of preterm preeclampsia with delivery before 37 weeks. Interestingly, they also found that less than 30% of the high-risk women, according to the NICE guidelines criteria, received aspirin in their hospital, but of those who had combined screening, 99% of the high-risk women received aspirin. So compliance seems much, much better with combined screening compared to screening by maternal history alone. There are now some cost-effectiveness studies that were published. This is a Canadian cost-effectiveness study suggesting that the cost of screening by maternal history alone is significantly higher, because you have to deal with a lot more disease and complications of disease compared to when you have a policy of screening with combined tests. and then prescribe aspirin to high-risk women. This new evidence has been causing changes to various guidelines around the world. This is the International Society of Ultrasound in Obstetrics and Gynecology recommendations and the new guidelines that were published after this evidence came out, and they stress in their guidelines that the combination of maternal factors, maternal arterial blood pressure, uterine artery Doppler, and placental growth factor at 11 to 14 weeks is the most efficient method of screening to identify women at high risk. And that given the superiority of this combined model, the use of ultrasound cutoffs alone are not recommended. The same goes for the International Society for the Study of Hypertension in Pregnancy, that also recognizes now first trimester combined screening as the best modality of risk identification, and that this should be used whenever possible within the context of the healthcare. And this is the FIGO guideline that came out in the last FIGO Congress, also suggesting that the combined test at 11 to 14 weeks is the most effective method of screening and should be the preferred method of screening even in low-risk settings, even if you need to use more simple forms of screening, including, for example, only history and mean arterial pressure. Now, a common question that I get is how to prescribe aspirin at 150 milligrams, which seems to be the ideal dose, and the standard aspirin tablet dose varies in different countries. So in the United Kingdom, for example, 75 milligrams is the standard dose, so then it's very easy. You can give 2 tablets, which equals 150. In the United States and in Canada, the standard dose is 81 milligrams. You could also give 2 tablets, which adds up to 162 milligrams. In Australia and in a large part of South America, the standard dose is 100 milligrams. You can give 1.5 tablets. You would have to discard the other half because it loses its effect for the next day. I'm not aware of any country that has tablets of 150 milligrams. And in Australia, we also have 300 milligrams. So you could give half of a 300 milligram tablet and discard the other half. Now, another important aspect that is coming up in the literature in the last few years, if 5, 10 years ago, most guidelines were not recognizing a proven effect of aspirin in reducing preeclampsia, now the question is, why not give aspirin to every pregnant woman? It's a safe and cheap intervention, and why bother doing screening with complex tests? The arguments not to give aspirin to every pregnant woman is that we don't really know if this intervention will be effective when applied to the entire general obstetric population. Another important problem, and for me maybe one of the most important problems, is that when you prescribe to women who do not have a high risk or a recognized risk factor, adherence to treatment tends to be a lot lower. And we know that pregnant women are reluctant to take medication in pregnancy. And that will inevitably reduce the effectiveness of the intervention if people don't take the medication as they should. We also don't know what would happen in terms of side effects if you give aspirin to millions and millions of women. We know that aspirin seems safe in randomized trials that focus on high-risk populations, but we don't have that data in trials looking at the general population. In fact, a couple of randomized trials tried to give aspirin to women of the general population or without major risk factors, and what they found is a much, much lower compliance rate than what we found in the aspirin trial of only about 50%. Also, they showed no benefit of aspirin treatment in those populations, and in some cases, increased risk of minor bleeding episodes. So I don't think giving aspirin to everyone is a good idea. So in conclusion, prediction of preeclampsia should be done early because treatment only works if started before 16 weeks. It should preferably be done by combined screening, which is better than stratification by risk factors alone. Calcium supplementation helps when calcium intake is low, but it does not help in populations where calcium intake is appropriate. Aspirin at 150 milligrams, and that's the ideal dose, reduces preterm preeclampsia by more than 60% in high-risk women. Universal treatment, in my opinion, is a bad idea. Although treatment is safe, we would probably have a much lower adherence to treatment. The effectiveness is not well studied in low-risk populations, and there may be an increase in side effects if we were to give aspirin to all women. Thank you very much, and I'm happy to take questions.